Hello and welcome back to Tuberculosis Part 2, wherein we will cover prevalent guidelines, the patient categories and treatment regimens according to the prevalent guidelines. In Part 1, we have already seen what is tuberculosis, what were the hurdles in management, and how has the short course treatment finally devised. And now we'll go on to see the changed, altered prevalent patient categories, which have had to be changed because of emergence of resistance and the current treatment regimens, taking into consideration that resistance is being observed. So revised guidelines, which came into force in 2016 are still being used. According to this, the two important categories of patients are drug-sensitive tuberculosis and patients having drug-resistant tuberculosis. Drug-sensitive patients can be further divided into newly diagnosed, treatment-naive patients, that means who have never received anti-TB treatment before. And the second subgroup is those which have received treatment for tuberculosis previously, but for some reason, they're again manifesting with tuberculosis or continue to manifest with tuberculosis, which is still sensitive to the drugs. And this distinct categorization of patients as drug sensitive and drug resistant at the outset, at the start of the treatment, before we start the treatment, is possible today because of advanced technology which has given us rapid diagnostic tests to ascertain the drug sensitivity pattern or drug resistance pattern of the microbes in that particular patient. So drug resistant group is further categorized into various subcategories. Earlier it was just MDR. And now we have various subcategories, and the worst of them is extensively drug-resistant tuberculosis, called as XDR. We will go on to see the different subtypes. So MDR TB is the multi-drug resistant tuberculosis, which means resistance to both rifampicin and INH, both the key drugs in the short course regimen. Resistance has developed to them. Earlier, MDR TB was defined as resistance to both RNH or even just resistance to rifampicin. Now, only rifampicin resistant has been defined as a separate category. So we have MDR TB, multi-drug resistant, where there is resistance to both rifampicin and INH. And the next is rifampicin resistant tuberculosis, where there is only resistance to rifampicin. Monodrug resistance is when there is resistance to one of the first line drugs, but not to rifampicin. Rifampicin is still working. That's a major distinction. Polydrug resistance talks about patients where there is resistance to more than one first line drugs, but again, not rifampicin. So whether rifampicin still works or not makes a big difference, as you will see in the treatment strategies for this tuberculosis. And now we are landed with extensively drug-resistant tuberculosis, where there is resistance to rifampicin as well as INH, plus one of the fluoroquinolones, plus one of the injectable drugs. So there is resistance to one injectable, that is group 2 drug, plus one fluoroquinolone, which is group 3 drug, and of course RNH, which is extensively drug-resistant tuberculosis and very, very difficult to manage, and these patients have very bad prognosis. Let's go on to study the actual treatment regimens advised for these different patients. So for treatment drug-sensitive tuberculosis, as we said, we have two subtypes, two subclasses, new patients and previously treated patients. So for new patients who have never been treated for tuberculosis, the duration continues to be 6 months with 2 months of 4 drugs. But unlike earlier, when continuation phase was 4 months with 2 drugs, now it is 3 drugs. So all new patients receive HRZE for 2 months, which is the initial intensive phase. And for the subsequent 4 months, they are given 3 drugs instead of 2. So it is 4 months of INH, rifampicin, and ethambutol. So ethambutol has continued into the continuation phase. For all previously treated patients, maybe defaulters or maybe non-responders, but bacilli show sensitivity to these drugs, the treatment is prolonged to 8 months. So there's one extra drug and one extra month in intensive phase, plus the continuation phase is extended to 5 months. So for 2 initial months of the intensive phase, the patient receives HRZE plus an injection of streptomycin every day. Then 1 more month, only streptomycin is omitted, but the patient receives H, R, Z, and E, 4 drugs. And in subsequent 5 months, he receives H, R, and E, INH, rifampicin, and ethambutol. So these are the 2 treatment strategies for patients with drug-sensitive tuberculosis. New patients continue to get 6 months of short course treatment. Only difference from the earlier short course is that ethambutol is continued into the continuation phase. And any previously treated but still sensitive to all these first-line drugs, the treatment is extended to 8 months. The numerical prefix, as you can understand in this table, is it indicates the number of months for which the patient gets those 4 drugs or 5 drugs or 3 drugs. Coming to drug-resistant categories. So MDR, according to drug-resistant categories of 2016, is resistance to R as well as H, rifampicin as well as INH. And you can see the treatment duration jumps to more than 2 years. So it's 24 to 27 months, where the intensive phase, initial intensive phase, can be 6 months or even 9 months duration. In this intensive phase, we continue the 2 first-line oral drugs which are still working, that is pyrazinamide and ethambutol. RNH, there is no response, but pyrazinamide and ethambutol are working, so they are used. And instead of RNH, we are adding 4 more other drugs. So from group 2, kanamycin is the preferred injectable used, and group 3 fluoroquinolones, levofloxacin is the preferred fluoroquinolone as per the RNTCP guidelines. And we also add 2 drugs from the other oral agents, that's group 4, ethionamide and cycloserine. Out of these 6 drugs, as we discussed, pyrazinamide has a major role in the intensive phase, not subsequently. So that is omitted, and the injectable is omitted. So kanamycin injection is omitted. And rest of the 4 drugs are continued for 18 months. So total duration of the treatment for MDR tuberculosis is 24 to 27 months. Though INH does not feature as one of the drugs here, we do need to give pyridoxine 100 milligrams once a day throughout the regimen, throughout the 24 to 27 months, because ethionamide and cycloserine, these 2 drugs also have neurotoxicity, which can be mitigated, which can be controlled by pyridoxine. So whether there is INH or not, for ethionamide and cycloserine, pyridoxine support treatment is important throughout the schedule. Coming to rifampicin resistant tuberculosis, where there is resistance only to rifampicin, all other 3 first-line oral drugs are working. Even then you see, even if just rifampicin is not working, the duration of the treatment is 24 months. That's the difference rifampicin can make. So the treatment for rifampicin resistant tuberculosis is the same as that for MDR tuberculosis. Only thing we add INH because it is still working. So all the above 6 drugs plus INH in the initial intensive phase, all the 4 above drugs plus INH for the continuation phase of 18 months, along with, of course, pyridoxine 100 milligrams once a day throughout the regimen. So this is the prolonged treatment required when there is a resistance to rifampicin. This will highlight the importance of rifampicin, because as we go on to the other 2 categories, mono and polydrug resistant tuberculosis, you can see that the duration of treatment is still less, more than 6 months total, but it's within an year. So monodrug resistant tuberculosis, where there is resistance to one first line oral drug, but not rifampicin. So rifampicin is working, and two of the other three drugs is working, then we continue these two effective drugs, first line drugs, plus rifampicin, and add just two more. So from group 2, kanamycin injection is added, and from group 3, levofloxacin is added. For continuation phase of 6 months, again we continued these first three first line agents, and only the injection is omitted, levofloxacin is continued. So this is a treatment of 9 to 12 months for monodrug resistant tuberculosis, where three of the first line drugs, including rifampicin, are still working. Polydrug resistance, there is resistance to more than one first line drugs, but not to rifampicin. So rifampicin we still have as an effective drug. Here again the duration is 9 to 12 months. So 3 to 6 months of intensive phase, we continue to use rifampicin and the one other effective drug from the first line agents. We add the two drugs as we added earlier, kanamycin injection from group 2 and levofloxacin from group 3, fluoroquinolone. Plus, we have to add one more drug from group 4, the other oral agents. It could be ethionamide, cycloserine, or para-aminosalicylic acid. And again, for continuation month, we omit the injection, continue rest of the drugs from intensive phase into the continuation phase of 6 months. So this is a treatment for monodrug resistant and polydrug resistant tuberculosis. The last and the most serious type of drug resistance is extensive drug resistant tuberculosis, where there is resistance to not only rifampicin and INH, also to one fluoroquinolone, also to one injectable drug. And when this is even suspected, if XDR-TB is suspected in a patient on MDR treatment, we immediately stop the MDR drugs to prevent further emergence of resistance. We have to immediately stop the existing schedule of MDR drugs and we change the drugs to others. So for XDR-TB, total duration is 24 to 36 months. 6 to 12 months of INH, high dose, that is 900 milligrams instead of 300 milligrams. So only INH is continued, but at a 3 times higher dose. Amongst the injectables, instead of kanamycin, it is capreomycin. Amongst fluoroquinolone group, it is moxifloxacin instead of levofloxacin. And from group 4, instead of ethionamide and cycloserine, we add para-aminosalicylic acid. And 3 drugs are added from group 5, clofazimine, linezolid, and amoxicillin clavulanic acid combination. In the intensive phase again, only the injection is omitted and rest of the drugs are continued. So injectable is used only in the intensive phase. The rest of the drugs continue in the continuation phase, of course, along with pyridoxine 100 milligrams per day throughout the duration of the treatment. That has to be given since we are using a high dose of INH. So these were the strategies or regimens used for either drug-sensitive tuberculosis or drug-resistant, any of these categories of resistance to tuberculosis or first-line tubercular drugs, anti-tubercular drugs. Coming to chemoprophylaxis, which is also referred to as prevention of latent tuberculosis. So chemoprophylaxis is not used randomly, but it is used in the contacts of tuberculosis patients where exposure is occurred, but the disease is not manifesting. So it's still latent stage. So who are the patients, who are the individuals who should be given this prophylactic treatment? So all contacts of open cases, sputum positive, who recently are showing MAN2 positive. So if they had MAN2 positive right from before, that's a different situation. Now they're in contact with a positive case, open case, and they've converted to MAN2 positive. That means they have acquired the infection just now. Less than 3-year-old children in families with sputum positive open case, neonate of a mother having tuberculosis, HIV contacts of sputum positive tuberculosis cases, and any immunocompromised patients who are in contact with open tuberculosis cases. Immunocompromised because they have comorbidities associated with immunocompromised status, that is leukemia, silicosis, diabetes, or they are on drugs which compromise their immunity like steroids or any other immunosuppressant agents. So what is the treatment given to these patients who definitely have got an exposure, recent exposure, but they are not yet manifesting the disease? That's latent tuberculosis. So drugs used are either INH alone or INH rifampicin combination. So if INH is used alone, it is given in the dose of 300 milligrams per day for adults or 10 milligrams per kilogram for children on a daily basis for 6 months. If we add rifampicin, again, that's the power of rifampicin, we can give the drugs just once a week and the total duration is only 3 months. So INH, it should be 15 milligrams per kilogram. INH 15 milligrams per kilogram. So it's a higher dose of INH, and rifampicin 10 milligrams per kilogram once a week for 3 months. That's the treatment strategy for chemoprophylaxis if we use INH plus rifampicin. Please note there's a correction in the slide. INH for this once a week treatment is 15 milligrams per kilogram and not 310 milligrams per kilogram. Okay, and rifampicin is 10 milligrams per kilogram. For management of tuberculosis in pregnancy, though otherwise rifampicin is considered contraindicated in pregnancy, for tuberculosis there's made an exception. So a patient with drug-sensitive tuberculosis developed during pregnancy is given the regular treatment for a new case with drug-sensitive tuberculosis. That is 2 months of HRZE and 4 months of HRNE. Along with the differences, along with pyridoxine, 10 to 25 milligrams per day. That's a regular treatment schedule. Remember, otherwise, rifampicin is considered contraindicated in pregnancy, but for tuberculosis, it's made an exception and this combination is thought to be safe. For the newborn baby of a mother having tuberculosis, we need to rule out severe tuberculosis at birth and then give BCG vaccine. And for 6 months, we give INH 10 milligrams per kilogram per day for 6 months, along with pyridoxine 5 milligrams per day. Another important aspect to remember, is there any role for corticosteroids in management of tuberculosis? When you studied corticosteroids, you must have studied that before starting corticosteroids for whatever other indication other than tuberculosis, you would rule out presence of infections like tuberculosis before we decide to start the treatment with corticosteroids. Why? Because corticosteroids have two important actions, anti-inflammatory and immunosuppressant action. And this immunosuppressant action could be troublesome. Therefore, routinely, corticosteroids are to be avoided if a patient has tuberculosis. But in case of serious tuberculosis, and you can remember the 3 M's, miliary tuberculosis, massive tuberculosis, or membranous, importantly meningitis, TB meningitis, we do use steroids for their anti-inflammatory action. Similarly, if a patient manifests with severe hypersensitivity reaction to any of these drugs which need to be used for tuberculosis control, to control this hypersensitivity, again we have to use corticosteroids. If it's tuberculosis of the adrenal glands themselves, compromising the release of natural amounts of corticosteroids, we would have to give corticosteroids as replacement therapy. So these are the 3 situations where corticosteroids are to be used either as anti-inflammatory action to control hypersensitivity or as replacement therapy. But while using tuberculosis, we must remember its immunosuppressant action and strictly adhere to the adequate treatment of tuberculosis with the recommended regimens. That is very, very important. If at all, steroids are required in a patient of tuberculosis. So in this part 2, we have studied what are the categories of patients as per the current status because of emergence of resistance, what are the drug regimens for drug-sensitive tuberculosis, various subtypes of drug-resistant tuberculosis, what do we do to protect patients of contacts or contacts of tuberculosis patients from developing frank disease, and what is the management of tuberculosis in pregnancy and the newborn baby of a lady with tuberculosis. So revise, recap, write down. Happy learning. Thank you.